thank you to everyone who has again spoken so far this morning. And we have a really nice segue, I think, to our next set of talks regarding intervention and the patient perspective. So first, I'm honored to introduce Dr. Karin Gehring. She is a neuropsychologist and senior researcher at the Department of Neurosurgery and the Department of Cognitive Neuropsychology at Tilburg University in the Netherlands. And her research is aimed at cognitive functioning in patients with primary and metastatic brain tumors and interventions thereof. And she's going to be speaking with us today about opportunities for pharmacologic interventions. Thank you so much, Dr. Gehring.
Thank you, Jenny, for the introduction and for inviting me here to present. Yes, I will talk about, I will give you a quick overview of the evidence on studies on interventions for cognitive deficits in patients with brain tumors. Besides developments in brain tumor treatments that attempt to spare cognition, actively aiming at prevention or treatment of cognitive impairment with specific intervention is as relevant as the cognitive impairments that are usually not too severe in patients with brain tumors, allow for intervention-related improvements. And patients, especially those with relatively young age and relatively favorable prognosis, often aim to resume a normal daily functioning. And I will discuss evidence from studies on pharmacological interventions, behavioral interventions, including cognitive rehabilitation and physical exercise. And a spoiler alert, there's little research in this area and many studies have methodological flaws. Therefore, I will focus on the larger randomized controlled studies with an emphasis on controlled. We all know the importance of a control group, but in studies with repeated cognitive testing, it is particularly important to control for improved neuropsychological performance due to the mere practice with neuropsychological tests. And along the way, I will discuss some aspects of studies and interventions that are important for the interpretation of study results and for the design of future studies. I will start with the pharmacological interventions. Several approaches have been done in a total of 10 studies. The choice of agents has often been based on presumably comparable mechanisms of cognitive impairments in other patient groups, such as stimulants for ADHD and donepezil and memantine for dementias. And in bold are the studies I selected for this presentation and to discuss in the short time I have now. Those are the studies with the better methodologies and interesting approaches. The studies on stimulants have not shown consistent effects, neither has ginkgo biloba, but donepezil and memantine have. And in general, those studies were rather small, as you can see, and often did not include control groups, as you can see. So conclusions are hard to draw, and many studies had problems with accrual, and it has been suggested that patients may be reluctant to use additional medication. Different approaches have been, different populations have been studied in these studies. Different types, grades, and treatments of brain tumors do not only affect the severity and the patterns of cognitive impairment, but also affect the cognitive courses over time in different ways. And we should be aware of that. We should be aware that these groups may differ in their responses to interventions and the maintenance thereof. As I said before, I will discuss the two largest best designed studies that also reported positive findings. To start with the right column, Brown and colleagues investigated the potential neuroprotective effects of memantine, an NMDA receptor antagonist, versus placebo in whole brain radiation during whole brain radiation therapy in patients with brain metastases. And 149 out of 508 patients completed the cognitive assessment at 24 weeks. After treatment, there was a non-significant trend of less decline in the late verbal recall, which was the primary endpoint of this study, for patients in the memantine arm. However, this group also showed significantly longer time to cognitive decline and reduced decline rates in several cognitive domains. And in such a study, where the aim is prevention or delay of cognitive decline, it is not necessary to employ eligibility criteria with respect to cognitive impairment. But if we aim for treatment of cognitive deficits, screening for presence of cognitive impairment may be helpful. And the aim of the study of the RCT of Rev and colleagues was to improve cognitive functioning in patients with primary and metastatic brain tumors who were irradiated at least 6 months before study participation. They investigated donepezil, a cholinergic neurotransmitter modulator, versus placebo, and patients did not need to have cognitive impairment. After 24 weeks of treatment, cognitive composite scores did not differ significantly between groups. However, significant differences favoring donepezil were observed for memory, motor speed, and dexterity. And interestingly, the benefits of donepezil were more pronounced for those who were more cognitively impaired. And according to clinicaltrials.gov, a randomized placebo-controlled trial on Nemzeric, combination of donepezil and memantine, in cranially irradiated cancer survivors is starting soon. I will now move on to the behavioral approaches. 12 studies have been conducted on cognitive rehabilitation in brain tumor patients, and they've included several approaches. 3 studies explored cognitive retraining, exercises that specifically target the cognitive deficits to improve impaired cognitive functioning, with lots of practice. For example, concentration exercises that are performed many times, often with use of computer. And 6 studies explored cognitive strategy training, which help an individual to find strategies to address daily cognitive functions, to address daily cognitive limitations in daily life, or combinations thereof, in 3 studies. And many studies had a multi-domain focusing on several cognitive domains at the same time. But again, here, these studies had several methodological limitations. Most studies included small samples, did not use statistical testing, or did not have a control group, which is problematic, as I explained before, when evaluating patients repeatedly with cognitive tests in which they improve. And the studies in bold here are the studies I selected for this presentation. And also in general, dropout in these studies was low, and adherence to the programs was sufficient. And most studies reported some benefits. So these are the more positive findings. Here as well, different approaches have been undertaken with respect to the timing of cognitive rehabilitation. Timing is relevant for a cognitive screening, as I explained before, but also for motivations of patients to participate in a program. In fact, experiencing cognitive problems may be a good motivation. But as patients may face cognitive problems in daily life not until after treatments have been completed, they may be more motivated to participate in late cognitive rehabilitation programs. But at the same time, early intervention may prevent that cognitive impairments grow worse over time. One study with the earliest delivery of cognitive rehabilitation was conducted by Sukeya and colleagues. They investigated a multi-domain program combining retraining with the computer and strategy training within 2 weeks after surgery, and patients did not undergo any further treatments during study participation. And after the intervention, patients in the intervention group showed improvements on tests of visual attention and verbal memory. But as this study may be considered a preventative study, it would have been interesting to see whether these effects would also maintain over time or after adjuvant treatments. So a long-term follow-up would have been welcome here. In most cognitive rehabilitation studies, patients were selected on the basis of tested cognitive deficits. Only a few used self-reports of cognitive dysfunction. And we should note here that self-perceived cognitive complaints have low associations with cognitive test performance. In the randomized controlled trial we conducted in 140 stable glioma patients, patients had both cognitive complaints and demonstrated at least mild cognitive impairments. They were randomized to an intervention versus control group, and only a few patients dropped out along the way. We visited patients at home for 6 weekly 2-hour sessions of cognitive rehabilitation, and they underwent multi-domain strategy training and attention retraining, and also had to do several hours per week of homework. Immediately after the intervention, patients reported fewer self-reported cognitive symptoms, and at longer-term follow-up, they demonstrated better attention and verbal memory scores with neuropsychological testing, and reported less mental fatigue. Individual level analysis indicated that younger patients benefited the most, and older patients reported more burden of the homework they had to do. One other important aspect to take into account is that an intervention should be implemented easily. Our rehabilitation program was not very feasible, having to visit all patients at home for 6 weeks throughout the Netherlands. And as a patient researcher initiative, we translated it into an iPad app called Remind to increase its availability and also to enable patients to train at their own pace, time, and place. We kept the content of the program largely the same as the original program, but also translated it into English. We conducted a feasibility study and a pilot RCT 3 months after surgery for low-grade glioma or meningioma. And we experienced actually some problems with recruitment, but the patients who participated in the intervention group on average completed 86% of the strategy training and 91% of the retraining. All patients indicated that they found the iPad a suitable mode of delivery of cognitive rehabilitation, and almost all indicated that they would recommend the app to other patients and gave a good to excellent rating. The statistical analysis were underpowered, but we saw some indication of improvement on cognitive tests of verbal memory, information processing speed, and complex attention, and also on patient-reported outcomes of cognitive symptoms, self-reported executive functioning, fatigue, and psychological well-being. And we concluded that the timing of such a program should be adapted to the patient's needs. This may have been too early in this study. Together with patients, caregivers, nurse practitioners, specialist nurses, I should say, and neuro-oncologists, we developed a care path for Remind for implementation in the Dutch clinical practice. And in the meantime, research on the English version is ongoing. And I think the next speakers will tell you more about that. And Dr. Frédéric Dermain, a radiation oncologist, has collected funding for a French version of Remind. And again, only a few studies, if we're going back to the rehabilitation studies, only a few studies evaluated the effects of the intervention at the level of self-perceived cognitive functioning. most tested cognitive performance with neuropsychological tests, and this is not different from the pharmacological studies. Self-report of strategy use may also be helpful here as well, but it remains difficult to determine how we can best measure success of an intervention. What type of measures capture the skills that patients use in daily life, or the skills that they have learned during rehabilitation? Although this is not the answer to this question, imaging techniques, and in particular functional fMRI, may be helpful to understand brain processes related to the potential effects of cognitive rehabilitation. Miyato and colleagues conducted a study using pre and post training fMRI scans to investigate task-related changes in activation associated with one session of strategy training of memory. And they did that in patients with glioma and meningioma in the prefrontal cortex. And after this 30-minute training, patients showed improved word recall and also an increased activation in the prefrontal cortex networks, which suggested compensatory processes by recruiting perilesional areas. And then I'll move on to the physical exercise approaches. Physical exercise has been shown to be effective for prevention or amelioration of cognitive deficits in healthy older and demented individuals. And we conducted a pilot RCT in 32 patients with stable lower grade gliomas. And patients could choose their own physical activity as long as they adhere to our individual exercise prescription. And that meant that they would exercise 6 months at home at an intensive aerobic exercise level. They used a heart rate monitor to keep track of that, and also received remote guidance of physical therapists. And after the intervention, we noted between groups small to medium effect size differences in favor of the intervention group for cardiorespiratory fitness as measured with PO2 peak, and also saw improved performance on several tests of multiple cognitive domains. And we also found consistent indications of better patient-reported outcomes after the intervention. Studies in other neurological patients suggested a synergistic effect of combining physical training and cognitive training. And we have actually developed a prototype of such a training and are now looking for funding for follow-up. To conclude, treatment with donepezil for patients with primary and metastatic brain tumors and memantine as prevention for patients with brain metastases may be helpful. And due to the slow course of cognitive damage in patients with brain tumors, many patients are capable to learn from cognitive rehabilitation and have proven to be compliant to such burdensome programs. But still, more research is needed, as you have seen. We need to consider the timing of interventions. Motivation is important, especially in effortful cognitive rehabilitation programs, or being willing to take additional medication. And an individual approach should be taken here, perhaps. And more prevention studies in patients with brain tumors may be targeted at the late delayed chronic adverse effects of radiotherapy, and such studies need long-term follow-up. And maybe this is obvious, but any treatment of cognitive deficit seems to work best in patients who have verified but not too severe cognitive impairments. We need control groups to control, especially for the practice effects of repeated neuropsychological testing, or other methods to control such effects, such as reliable change index. And we need to take into account the different brain tumor types and different treatment histories may have different cognitive courses over time. And of course, it remains difficult to capture the successes of intervention. Self-reported cognitive function may be as helpful as neuropsychological test performance, but also integration of neuroimaging techniques may help us understand the mechanisms underlying intervention effects. But other types of evaluation may be needed as well. For example, experience sampling during daily life. And I think we also may continue looking at research in other patient populations to find suggestions for interventions, such as virtual reality for cognitive rehabilitation. This has already been explored by young colleagues, but could be explored more. Non-invasive brain stimulation, exercise, perhaps also dance, and dietary intervention. And of course, a combination of approaches should also be very helpful. And we should keep in mind that interventions should be feasible to implement in daily clinical practice, or, and perhaps not only during COVID times, at home. Thank you for your attention. I would be happy to answer questions.
Thank you so much, Karin. I think having so much experience with these different interventions and what you've learned is just so valuable to all of us who are thinking about how we can help our patients. A couple of specific questions that had come up is you mentioned a few times the balance of when to try to apply these interventions for patients, either pharmacologically or even more so from a motivational perspective, non-pharmacologically. And I know you've got a wide range of experience, so I was hoping you could comment on sort of your gut instinct about how to try to optimize when to intervene.
Well, actually, I was giving this talk as a researcher, so then we have to adhere and stick to research protocols, and then it's difficult to play with the timing of intervention. But I think in clinical practice, patients themselves should indicate when they are able or in the right situation to undergo cognitive rehabilitation. We have seen that early after surgery, during radiotherapy, during chemo, this is not the right timing for all patients. For some it is, and for others it isn't.
Right, so sort of using a eligibility criteria for enrollment to include some subjective clinical perspective,
yeah,
as well as versus just a time point.
Yeah.
Yeah, great. And then I know in your work and in some of your colleagues' work that there's been this sort of notification of benefit that's a bit delayed. So a few months after the completion of the intervention, and even maybe that's true for pharmacologic and or non-pharmacologic options. I was wondering if you could comment on what you think the mechanism is behind that.
Well, for cognitive rehabilitation, it might be that it takes time for patients to integrate the strategies that they learn during cognitive rehabilitation in daily practice and start to use them in daily functioning. The difficult thing is whether you can measure that with neuropsychological testing. We seem to be able to measure that, but that's a difficult discussion. What measures are the most relevant to capture these effects? Long-term, short-term, subjective, or with neuropsychological tests? Yeah.
And then I think the final question that I would have is just, you alluded to the fact there's likely differences with different histologies, maybe within a particular glioma type, or certainly between primary versus metastatic versus extraaxial disease. Again, mechanistically, do you have a sense as to how to do that? Or should we, for these interventional research studies, be honing in on particular tumor subtypes?
Yeah, that is the difficult question, I think. I think we at least need to be aware of those differences in courses over time due to pathology. Yeah, we need larger samples to determine these things. If we have a large sample, we can do subset analyses to determine which patients benefit at which time. And that needs multi-center cooperation, I think.
Perfect. Thank you very, very much.